collaborations, and the resilient spirit of trauma professionals in Sri Lanka and beyond. We hope this day unfolds with insight, inspiration, and a collective drive to elevate trauma care to new heights.
As we set stage for our deep dive, we journey into one of the most intricate and fascinating realms of trauma care, neurotrauma. This session delves into the evolving science of the injured brain, from neurocognitive recovery after traumatic brain injury to advanced multimodal intracranial pressure monitoring and decompressive craniectomy in preserving life. These discussions weave a narrative of precision and innovation.
To guide us through this essential session, we're honored to welcome on stage two esteemed chairpersons. We warmly invite on stage Dr. Malin Gunawardena, consultant anesthetist at the National Hospital of Sri Lanka, and Dr. Surat Munasinghe, consultant neurosurgeon at the National Hospital of Sri Lanka.
Good morning, everyone. So let's start the Neurotrauma session. Welcome all to the National Trauma Conference. So we are starting with the neurosurgical session first. So the first speaker will be Dr. Chamara Jayathunga, and he's a consultant in rheumatology and rehabilitation medicine at the Rheumatology and Rehabilitation Hospital, Ragama, and the National Hospital of Sri Lanka. And he is also trained as a specialty doctor in neurorehabilitation at Royal Berkshire Hospital, UK. So he'll be talking about neurocognitive recovery after TBI. So let's welcome Dr. Chamara Jayathunga.
Good morning, ladies and gentlemen, and thank you very much for the kind introduction. Can I have the slides, please? Yeah. So the title of my talk would be Neurocognitive Recovery After Traumatic Brain Injury, and this would be the outline. I'll quickly highlight a few interesting facts about certain features of our population with regards to this topic. And then I will try to give an overview of rehab approach to a patient with neuropsychiatric problems after TBI, and then some key concepts of neurocognitive rehab. These data I gathered from the annual injury report of 2022, which is available online. Perhaps these were already discussed in this conference by now. So injuries are the #1 cause of hospitalization. And in 2020, the total number of admissions were 1.1 million. And leading mechanism was falls, followed by transport-related injuries. Limbs were the most affected, followed by head. And 5% of the victims were left with some kind of disability, but in my personal opinion, I think it must be a bit more than that. So definition of traumatic brain injury, according to the ICD-11, it's damage inflicted on the tissues of the brain by direct or indirect result of an external force, or with or without disruption of the structural continuity. Then definition of rehabilitation. This is a general definition, but it contains two key concepts of rehab in itself. So it's a set of interventions designed to optimize functioning, that is number one, and to reduce disability with an individual with any health condition in interactions with their environment. That's the second one. So by definition, rehab is individualized. The concepts are the same, but we can't force one person's rehab plan to another patient. And the primary purpose of rehab is to enable people to function in the highest possible level. We all work within physiological limits, so there can be limitations, even with cutting-edge advances in medicine. And the third point, rehab goes across the continuum of care. That's one of the key messages I wanted to share with this audience. So WHO is very keen on rehab because there's a big change in demographics. People are living longer, and but with certain problems. So this is one of the key concepts in this decade, and it was, I think, highlighted in the recently held WHO conference in Colombo. And it's an essential health service, and it's a value-added health service. It saves money, and it saves time when you take overall cost and the time lost for disability. And also, it's integrated to all levels of healthcare. Sorry, the screen is located a bit away. So why do we need rehab? Because, as I mentioned, there's a change in the demographics, and WHO estimates that 1 in 3 in the world will need some sort of rehab, and it includes trauma as well as cognitive impairments. I would take a couple of minutes to go through this slide. I just wanted to share with this audience. So this is what I meant by rehabilitations requiring across the continuum of care. So that's fine. So rehabilitation should happen at pre-hospital level, and then this applies to trauma as well as for non-trauma, and then there should be some sort of rehab happening at the acute hospital, and then when the patient, if the patient requires ICU care, there should be certain rehab happening there. These services, we have established services in Sri Lanka, and then if the patient recovers, patient will be discharged home. But for a subset of patients who will continue to have residual functional limitation, then these patients will need further rehab, and there are 3 agreed level of rehab at the moment in Sri Lanka. This I obtained from the 2024 National Rehab Guideline published by the Ministry of Health. So specialized rehab hospitals, which we have at the moment, and then hospitals with rehab units. We have certain level, but there's some more to be developed. And then hospitals with rehab services, which is also established at the moment. And then patient goes back to the community, and then we need the community rehab services, which is a bit of a challenge at the moment. Right, so rehab approach to any patient, any disability, including cognitive disability. This is the suggested framework. It's a 5-step approach. So we're going to identify the disability, detailed assessments, goal planning, outcome measures, therapy or treatment. Skip. So identifying the problem, there are so many models of disability, and this is the preferred method internationally as well as personally myself, which is proposed by WHO in 2001, which is the ICF, like the ICD for diseases. For all the body functions, there's a classification called International Classification of Functioning, available online. And it's based on biopsychosocial model, and it divides these functions into 5 main categories: impaired body structure and function, activity limitation, participation restriction. Those 3 are called a disability, But that disability depends on environmental and personal factors. So we'll try to apply this to a patient with traumatic brain injury. So what are the affected body structure and function? So there's so many. There can be limb weakness, there can be language problems, cognitive problems, there can be swallowing, bladder, bowel, psychological, as well as potential medical problems. So impaired activities can be mobility, self-care, transferring, walking, communication, and then restriction of participation, going to work, leisure, social activities, religious activities. So any problem in these three categories is a disability. But that depends on personal factors, age, gender, level of motivation, insight, type of personality, as well as these environmental problems like geographical and social problems. Now, what's the importance of getting this deep dive into the problem? Because now we know whom to refer, what are the things we can perhaps improve, and this will help us to set realistic goals. And cognitive rehab, remember, it's time-consuming, it's costly, so, and there's an overlap between other domains as well. So when we see a patient with neurocognitive problems after TBI, the rehab approach is to work on all these domains so that improvement in one domain will help the neurocognitive domain as well. For example, a patient with neurocognitive problems plus reduced mobility. If the mobility is the relative strength, perhaps we can work on that, and then perhaps we can change certain modification in his environment, maybe at home or his workplace, maybe at a reduced capacity. Let the patient engage in the participation so that the neurocognitive impairment will improve subsequently. So that's how we work. But of course, we try to improve the neurocognitive thing as the primary thing. We always try, but sometimes it might not be possible, so we try to work on the other domains as well. Right, step 2, now we identify the problems. That will take some time. Sometimes patient's history is not accurate, so we might have to go to the records, give a call to the previous unit, speak to the family, and then we map that, and then we do detailed assessments depending on the main problems. So I've listed out what we do, and we have cognitive screening tools like MOCA, but that's only screening. It just divides the patient to high risk and low risk. We do not have access readily to detailed cognitive assessments, which is generally done by neuropsychologists. But if we have challenging patients, you can refer to detailed neurocognitive assessments. I have listed out a few. And certain patients, especially the patients with advanced neurocognitive problems, we call it prolonged disorders of consciousness. We can use this freely available coma recovery scale that will help to categorize the patient as well as to monitor the improvements. And then nutrition and also the sleep wake cycle, as well as reviewing the medication list is also very important. So severity of traumatic brain injury, there are various ways to categorize. And then these medicines, now I have to be very clear with this message. So these medicines theoretically can impair with neurocognitive rehab, but sometimes we might have to use very cautiously to treat certain problems or manifestations of these patients. So it's a very delicate balance. But we try to, if we are using the general approach from rehab point of view, is to use the lowest effective dose with very careful monitoring and frequent reviews. So this is the coma recovery scale, very good and easy to use. You can delegate this sometimes to therapy teams as well. So, escape. Right, goal planning, key concept in rehab. And a goal is the intended outcome from a specific set of interventions. The first thing is to ask the patient, what do you want? But in neurocognitive impaired patients, sometimes it might not be very straightforward. So we have to get the pre-morbid functional level and ask sometimes the goal may be in best interest by two specialists agreeing with the next of kin. So goals have to be always smart as in other personal goals. So the domain that I need to highlight is the timed. So we have noticed in our healthcare, sometimes we don't pay a lot of attention to the time, but resources are limited, patients are increasing, so I would encourage you to put a time. And that depends on clinical experience of the rehab team, patient preference, as well as the natural history of the condition. So I will just highlight a few goals for a patient with very severe neurocognitive problems, like in a low awareness state. So low awareness state is an umbrella term which is used in rehab practice, which includes 3 categories. One is coma. The better one would be vegetative state, and the next better conscious level would be minimally conscious. So all 3. It's difficult to assess or categorize with a snapshot assessment, so we need serial assessments. But when you're not sure, we use the word low awareness state. For such patient, it's very important to prevent further problems. So I have listed out common goals. And I would like to highlight on the third goal. So in a patient with severe neurocognitive problems, one of the key concepts of rehab is the verticalization. We need to get the patients to the vertical position, either standing with a tilt bed, if stable, of course, or at least with supported sitting, because otherwise patient's visual axis, if the patient is supine, will be to the ceiling. So the interactions are less. So that's why we work as a team. We get the mobility, we get the balance, so the patient can interact more with the environment. So verticalization. And the 5th one, ensuring that family are aware of the next steps. That's very important. And we do not have our own patient information data at the moment, so you can refer the family to this website, which is Headway, which has a lot of resources for family and carers. Not only for PDOC patients, even with anybody with mild cognitive, even with lesser levels of cognitive impairment. So the rehab goals continuing. Pain relief. Pain can be felt even the patient is in a maybe in a low awareness state, so always see whether the patient is having pain. It's a best interest decision. Maybe you can prescribe very simple form analgesics, maybe during therapy times. So some goals, I will skip in interest of time. Goal attainment scale we use in rehab. So we identified the problems, we did detailed assessment, we set goals, now we need an outcome measure. This database is freely available. You can just search what's the condition you are treating, and you will see so many outcome measures. Some are free, some you need to pay. And when I searched traumatic brain injury, there were, I think, over 100 results. And you can put filters as well, what you're going to achieve. Mobility, cognition, memory, whatever you want. And then step 5, the rehab intervention. So the problems are complex, so we need a team. And teamwork is very good, but teamwork has its own downside as well. So there should be a team leader, otherwise there's no accountability. When the goal is not met, there's nobody to take the accountability. So team leader depends on the setup, but in an ideal setting, generally it's led by a consultant in rehab medicine, and then we need inputs from other specialists, doctors, nurses, physios, so full team we have in certain hospitals. And for neurocognitive concerns, inputs from the clinical neuropsychologist, if available, will be very handy. When the patient is at a very impaired level, we can work with the occupational therapist, but for subtle and detailed, like return to work, return to driving, return to highly skilled sort of employment, we might get inputs from neuropsychologists if available. So in Sri Lanka, patients with disability are managed by 2 departments, Ministry of Health as well as the Ministry of Social Services. So we have certain allowances. So I have listed out, this is a RRH form. So the general idea is to tell the patient to go to the nearest divisional secretariat office and meet the social worker and get the form set, and then any doctor can fill it and can get your therapist to do certain assessments. And then there are allowances and facilities available, and we have to ask the patient to follow it up. It's not Ministry of Health. But we do have certain budgetary allocations The amounts are not very fancy, but we have. Right, some key points in neuro rehab. I have, it's a very high-end talk in rehab, so I have just put some common principles. So the first point is very important. The overall goal is to minimize functional limitations and to facilitate safe, independent activities as well as quality of life. And it's achieved by a combination of restorative as well as compensatory strategies. Problem orientation is very important. The patient and the family should understand that there's a problem, and then we give a strategy. The goal is to make sure that patient uses the strategy after identifying that there's a problem. And these cognitive rehab principles are very effective, mainly in mild to moderate, but in severe, like in prolonged disorder of consciousness, we have a different approach. So internalization is a concept we use, and generalization is also a concept. Like, I mean, we can't train people on all the cognitive domains of the brain. Human brain is so powerful. So there's a concept in rehab that if we practice certain things, patient will generalize it to other settings and tasks. So compensation versus true recovery. I think the name itself explains it. So historically, it was more compensatory approaches. Like for mobility, let's say I have an arm and leg weakness, maybe I might be told to do my dressing using my other arm. But now, and for cognitive rehab, there are compensatory strategies like checklists, alarms, reminders, notebooks, right? But now the concept is we use both. True recovery, that is to regain the lost function, as well as the compensatory things, depending on what the patient wants. For example, patient might say, I need to go to work quickly. So maybe, yeah, if that's what's needed, maybe compensatory strategies plus some other activities to regain the lost one. So it's all very dynamic and patient-centered. So for true recovery, we use the neuroplasticity, which is the brain inherent ability to change and adapt. It's very powerful. And some key factors for brain recovery, which can be used for cognitive rehab as well, very important. Repetitions, duration, and these are very difficult tasks for certain patients, so we had to be very flexible as the rehab team. We had to tell the family they might not like these activities. So when the patient is very impaired, we might go for functional tasks rather than pen and paper-based tasks. For example, in my practice, I generally ask them, what are the hobbies and what sort of activities does this patient enjoy? Maybe cooking, maybe gardening, maybe jogging, whatever the patient likes. We have to use maybe music and then use that. And then with that, hoping that patient will internalize and generalize. And then when the patient improves, that can be done with the occupational therapist. And when the patient improves, then we might need neuropsych evaluation and pen and paper-based rehab approaches. Couple of slides. Only I will be very quick. So medication, we have certain options, but there's no very solid data to use. They have their own benefits as well as side effects. And these patients usually cannot give capacity. They do not have mental capacity as well. So we have to be very careful when we treat. We do treat, but then generally it's a best interest. So two specialists agreeing, and then next of kin or the family being informed, low doses, careful monitoring, and keeping in mind that this might be not useful all the time. So the options are methylphenidate, amantadine, donepezil, depending on the cognitive problem we have. So post-traumatic amnesia, skip that. Yes, so that brings to the end of the talk. So what I wanted to give you was an overview of cognitive rehab to a patient with neurocognitive impairments. The key messages are, of course, we do try to improve the impaired neurocognitive domains, but there are overlapping areas, so parallelly we might be working on other domains as well. And the overall target is to improve functional level and to be safe and the quality of life. And we have to set smart goals and be flexible and adapt the approach depending on the patient's response, as well as these patients can have, I skipped that slide, please remember they can have medical problems which can manifest as neuropsychiatric symptoms. Very commonly infection, severe itching due to fungal infections. Always remember, they are wearing incontinent pads in hot and humid weather. They can have candida or like moisture-associated dermatitis. And with a traumatic brain injury, patient is, because there's a language problem, so patient might not be able to communicate that, and it can be manifested as a behavior change, and we might put him on haloperidol. Right? So always do a full thorough examination, do a full blood count CRP. If those are normal, medication review done, no fungal or those infection, and these people sometimes are on NG, so they can have reflux. And the differential diagnosis for a reflux is acute MI, right? So it's very severe, but they can't communicate it. So put them on anti-reflux medication in best interest. So those are very important. Not all the manifestations are neurocognitive, so very tricky, time-consuming, I know, but that is how these patients are. They are a special cohort of patients. Mild to moderate can be done at home, like prolonged disorder of consciousness, like severe neuropsychiatric, maybe will benefit from inpatient intensive rehab. And it's best delivered by inputs from MDT. So again, overlapping goals. Occupational therapies are very important in this form of rehab, but sometimes we might need neuropsychology as well, which we do not have in the government sector at the moment. And Sri Lanka certainly has well-established pathways, very happy to say, and very grateful to everybody who was involved. But we do have challenges, especially in the community rehab pathways. So that's for the next maybe 4 to 5 years to work on. And special thanks goes to all my teachers and my patients, from whom we learn a lot. And thank you very much for your attention. I'm happy to take if there are any questions.
Thank you, Chamara, for your very informative talk. Are there any questions from the audience? We can have just one quick question if you have, or else we can have it at the end of the session.
Okay.
Right.
Thank you. So we'll go on to our second speaker, who's going to be Dr. Eranda Sanjeewa, and he's going to talk to us on advanced multimodal monitoring and ICP monitoring. He's a consultant intensivist at the Neurotrauma unit of the National Hospital of Sri Lanka, and he also has a wide experience, along with his experience in anesthesia intensive care as a specialty registrar at the University Hospital, Sussex, UK. So over to you, Eranda.
Good morning, everyone. Thank you very much, sir, for your kind introduction. After listening to rehabilitation, I'm going to take you through intracranial pressure monitoring and advanced multimodal monitoring. During my talk, I will be discussing on these subtopics, so mainly concentrating on intracranial pressure monitoring and advanced neuro monitoring. Traumatic brain injury, it's a global burden. So it considers Sri Lanka as a low and middle income country. It's a huge burden. We get a lot of patients every day to the accident service as well as intensive care units. So therefore, but apart from morbidity, morbidity is a major concern as we discuss about rehabilitation. So it's a huge economic and social economic burden to a country like us. So what is our responsibility? As medical professions, we can't prevent primary brain injury, the injury that happened at the time of the impact. What we can do is to mitigate and prevent secondary brain injuries. That is controlling the pathophysiological changes and managing brain-body interaction in order to mitigate the pathophysiological changes which can cause detrimental effect to a person. Considering that, the important fact is that we need to have an idea what's happening inside the brain. So brain target monitoring is very much important. So a lot of consensus in good practice are concerned on targeting on intracranial pressure measurement and intracranial pressure management, because intracranial pressure crisis has been shown has a lot of detrimental effect and poor outcome following traumatic brain injury. Considering intracranial pressure, a lot of recent guidelines, they emphasize the importance of measurement of intracranial pressure, like Brain Trauma Foundation guideline, where level 2 evidence to monitor intracranial pressure in conditions such as low GCS with abnormal CTs, and if the low with GCS less than 8, even with normal CT, if they have age of more than 40, systolic blood pressure more than 90, they have bilateral or unilateral motor posturing, it is recommended to measure intracranial pressure. The recent guideline, like CIBIC guideline 2019, they got more liberal use of intracranial pressure monitoring. So if we talk about intracranial pressure, the well famous Monroe-Kelly doctrine, which is the pressure exerted inside the cranial cavity by the content inside, like brain matter, CSF, and venous blood. So the physiological changes following traumatic brain injury. So if we think the normal intracranial pressure is 5 to 15 millimeters of mercury, with the expansion of brain matter due to cerebral edema, there is a compensatory mechanism which leaving fluids out of the cranial cavity. But at some point, when the compensation is exhausted, ERBB increase intracranial pressure, which compromise intracranial blood flow, leading to brain ischemia. When the intracranial pressure exceeds a critical volume, then there will be an exponential rise in intracranial pressure, leading to brain herniation and death. That is the pathophysiological mechanism that happened following traumatic brain injury, which can be explained along with the Monroe-Kelly doctrine. So we need to monitor the intracranial pressure. So what are the ways and methods available? We have invasive methods as well as non-invasive methods. So the external ventricular drainage and intracranial bolt, they are used as the invasive methods. Apart from that, there are non-invasive methods such as optic nerve sheath diameter and transcranial Doppler. External ventricular catheter, a catheter which is inserted to the ventricles, which considered as a closed system, which drain into a drainage bag, which diverts CSF from high pressure to low pressure, where we can divert the CSF at the same time we can measure the intracranial pressure, which is considered as the gold standard of measuring intracranial pressure. The other method, microtransducer, which a probe which drilled through the skull bone, which inserted to the brain parenchyma, which gives a local intracranial pressure as well as graphical representation of intracranial pressure along with the arterial waveform. So we have a number and a wave pattern. So both these ventricular catheters and intracranial bolt, there are their own advantages and disadvantages. However, ventricular catheter, which can divert CSF, which is a more added advantage in contrast to the ICP bolt. Both these instruments, the equipment, we can get an intracranial pressure waveform which showed the graphical representation of the intracranial pressure. So depending on that, we can observe the compliance in the intracranial cavity, which is important in the management of patients. So we can target our therapy, we can titrate accordingly, according to the intracranial pressure value as well as the characteristic of intracranial pressure waveform. The other non-invasive methods like optic nerve sheath diameter, where we can keep the high frequency linear probe on the patient's eye, and we can visualize the optic nerve sheath. Depending on the diameter, it's not a real-time one, but we can measure the trend of the optic nerve sheath diameter, which is a non-invasive method, can be used where in institutions where they don't have invasive intracranial pressure monitoring. The other non-invasive method, intracranial Doppler, which measures the blood flow, and according to an equation, it converts to a value of intracranial pressure. Again, a non-invasive monitoring method which can be used in the place where you don't have invasive intracranial pressure monitoring. Why we measure this intracranial pressure? So the perfusion depends on the intracranial pressure. As we know, if you have to maintain the cerebral perfusion pressure in order to perfuse the injured brain, so if we know the intracranial pressure value, so we can titrate the map accordingly and we can reduce the intracranial pressure accordingly. So the modern evidence, the level 2 evidence by Brain Trauma Foundation is to maintain cerebral perfusion pressure of 60 to 70 and control the intracranial pressure less than 20, which will give a favorable outcome. Not only that, in the intensive care management also, we titrate all our management strategies according to the intracranial pressure value. So we titrate our management according to the value. The cutoff is 22. If you measure the intracranial pressure, then our management is according to that. If intracranial pressure is less than 22, we position the patient and do our general intensive care management. If intracranial pressure goes up, we escalate our management accordingly. We ventilate them, we carry osmotherapy, and in available cases, we can divert the CSF as well. If intracranial pressure goes up more than 22 in spite of our medical management, still we can escalate our management. We can do mild hypocapnia and neuromuscular blockage. However, if it is not amenable to medical management, then it's up to surgeons who do the decompressive craniectomy. All these management is tear-guided newer approach is according to the intracranial pressure management. Moving beyond intracranial pressure, what are the advanced neuro monitoring available? To measure the cerebral oxygenation, we have jugular venous oxygen saturation, near-infrared spectroscopy, and brain tissue oxygenation. To measure the cerebral blood flow, then transcranial Doppler and thermal diffusion flowmetry. Ultimately, what happened inside the cellular level, about the cerebral metabolism, what happened inside. So it can be measured by cerebral microdialysis. Moving to oxygen measurement, jugular venous oxygen saturation, which gives a global value. So you can get the balance between oxygen supply and the demand. Depending on that, we can get an idea about how much of oxygen is being utilized. That is jugular venous oxygen saturation. Then we can measure the partial pressure oxygen inside the brain tissue, inside the neuronal cell, which gives a better idea about the oxygen level at cellular level. Though we maintain adequate intracranial pressure, adequate cerebral perfusion pressure, it is not guaranteed that cellular cell in the intracranial cavity which is getting adequate amount of oxygen. Therefore, brain tissue oxygen measurement is important. It is coming up in the future management, and trials have been proven it is given more independent, better outcome in contrast with only ICP and CPP management. Apart from that, to measure the oxygen level, we have a non-invasive methods as well. Near-infrared spectroscopy, which gives an idea about regional oxygenation. Infrared emission and absorption. Depending on that, it will convert to a value which can we can assess the trend of the value and have an idea about the regional oxygenation. Then the million-dollar question, what happened at the cellular level? We are providing oxygen, we are providing glucose, and we are maintaining cerebral perfusion pressure. Can the cell utilize the oxygen and glucose that we provide? Which gives an idea about the anaerobic and aerobic metabolism. So end product of the anaerobic metabolism is lactate, measuring lactate pyruvate ratio, which gives a better idea what's actually happening at the cellular level. Moving to non-invasive other methods, the function of the cortex can be measured by the measurement of EEG, the electro EEG activity. So the newer intensive care management emphasizes the importance of continuous EEG management in a patient with traumatic brain injury, which can identify the seizures, and we can identify non-convulsive seizures as well. So it has proven to be a better outcome if we can monitor the continuous EEG. At the same time, this conservative and quantitative EEG, which gives a value of the waveform according to the blood flow as well. Moving to the images, there are a lot of imaging modalities which can be used to measure the cerebral blood flow. The perfusion can, which gives an idea about the ischemic penumbra. Then with the scanning, we can get an idea about the ischemic penumbra and the differentiate penumbra areas with infarcted areas. So we can titrate our management according to that value. There are nuclear medical method as well, position emission tomography and SPECT called single photon emission computed chromatography, where we can have an idea about cerebral blood flow. It gives a color-coded 3D imaging where the clinician can have an idea about the blood flow to the affected areas of the brain. Not only that, there are newer biomarkers arriving. So depending on the damage to the cell, the inflammatory markers are being released into the bloodstream, like in cardiac biomarkers. There are certain biomarkers which can be measured in the blood, which can give an idea about the severity of the damage as well as the recovery, that is the recovery of the prognosis of the neuronal cells depending on the biomarkers. Therefore, the invasive and non-invasive multimodal neuromonitoring in traumatic brain injury, when we take everything together, the structural neuromonitoring with CT scans, MRI, and optic nerve sheath diameter, combined with brain tissue oxygenation and intracranial pressure, the value of the intracranial pressure as well as the oxygenation at cellular level, in combination with EEG values, where the somatosensory walk potentials and the continuous EEG measurement, combination with biomarkers, which gives a better value for the clinician to have an idea about what happened inside this black box. So it can be easier to titrate according to the physiology of the patient as well as the severity of the injury. So we call it precision medicine in terms of management of traumatic brain injury. Moving to the future aspect, it is the real-time neuromonitoring dashboard. As I mentioned, making everything together, the structural values as well as the dynamic physiological changes of the patient as well as the dynamicity of the pattern of the traumatic brain injury, which makes everything together, which give a precision physiological management to each and every patient, which can be tailored according to the patient's physiology as well as the severity of the injury. So to sum up, aggressive identification of management of secondary brain injury is important because as medical practitioners, that is what we can do, as we can't do anything to the primary brain injury which happened at the time of the injury. Brain targeted monitoring is important, so we can have an objective. We have a value, so we titrate our management accordingly, according to the intracranial pressure value, and according to our management can be titrated along with the value. At the same time, there are advanced multimodal monitoring, which can be measured the cerebral blood flow, cerebral oxygenation, and the metabolism of the brain, which combine with the EEG values as well as non-invasive imaging, which can put everything together as a real-time neuromonitoring dashboard, which will be a better outcome to patients following traumatic brain injury. Thank you so much. If you have any questions, I'm happy to take over.
Thank you, Sanjeewa, for that very comprehensive presentation on multimodal monitoring and ICP monitoring. We can take a question or two because we have a little time. If not, we'll go on to the next speaker and we can take the questions at the end. Thank you.
Thank you.
Our next speaker is Dr. Nirukshan Jayaweera. He's a senior consultant neurosurgeon at National Hospital of Sri Lanka with special interest in neurotrauma, minimally invasive spine surgery, and complex pediatric craniofacial and spinal disruption procedures. And he has international experience from his role as a specialty registrar in neurosurgery at Hurstwood Park Neurosurgical Center. And he's also the president of the Neurosurgical Association of Sri Lanka. He'll be talking about decompressive craniectomy and traumatic brain injury, whether it's life-saving or disability prolonging.
Good morning, everybody. Thank you, Sirat, for the kind introduction. Yeah, so when it comes to neurosurgery, so having given Dr. Sanjeeva's lecture, he has taken half of my lecture, so that's good. so I have only to operate on this patient. And yeah, so following head injury, so we see this kind of CT scans. So this, I have shown 3 CT scans. The first one shows very tight brain, the severe cerebral edema, and ventricles are effaced, and subarachnoid hemorrhage, and there's a film of subdural hemorrhage, so which indicates severe head injury. And the second CT scan in the middle shows the acute subdural hemorrhage with midline shift. And the third one, which shows again the left side acute subdural hemorrhage with some component of intracranial hemorrhage and the midline shift and the evidence of hydrocephalus, and surrounding the injured site of the brain there are some evidence of hypoxic ischemic injury. So which all these things cause the increased intracranial pressure. So edema, space occupying lesions, and hydrocephalus. Edema in the sense due to following the traumatic brain injury due to the cellular injury, cellular response to trauma, and pump failure, and ischemic insult, and cytoskeletal breakdown. These cause the intracranial pressure increase due to the cerebral edema. And space occupying lesions like EDH, SDH, and cerebral contusions which cause the increased intracranial pressure. And sometimes because of the obstructive hydrocephalus due to these mass lesions can cause the edema, the intracranial pressure rising. So all these things contribute to the raised intracranial pressure. So what happens when the intracranial pressure rises? So as Dr. Sanjeewa also described, this is a Monro-Kelly doctrine. So our head is the skull is a static volume. Inside that it has the venous blood, arterial blood, and the brain, and the CSF. So these things are in equilibrium to maintain the intracranial pressure within certain limits, and at least it tries to keep less than 20 millimeter mercury. So when there is an additional volume appears, which called the space occupying lesion, which shown in purple color, so it takes some space. So then the pressure changes, pressure dynamics changes, and brain goes into auto-regulation, and it tries to maintain the intracranial pressure. Thereby it can send out some of its venous blood and some CSF and goes back into the equilibrium to maintain the intracranial pressure. But what happened when the further increase in space occupying lesion? So then all the CSF has gone out and the venous blood, which is shown in blue, has gone out. Remaining is the brain and the arterial blood. So where the problem comes. So when with increase in ICP, if it going to reduce the arterial blood, that eventually the blood supply to the brain, so brain going to starve of oxygen and nutrients. So then brain becomes ischemic. And if the brain try to move out, which called the brain herniation. think there's some technical failure. So while they are sorting that out, we can take some questions from the previous two speakers.
Are there any questions? Are there any questions from the audience? So let me invite Dr. Sanjeewa to come and join to chair the session as well. Any questions for the previous speakers? Excellent presentation, Dr. Sanjeewa, regarding the multimodality ICP monitoring.
So we were talking about the rest intracranial pressure and what is Montegrelli doctrine. So then all the CSF has gone out, venous blood has gone out, then the brain has to compromise with arterial blood and the brain matter. So I said that when the arterial blood compromise, the brain perfusion reduce and then brain becomes ischemic. And when the brain matter is to push out, then which we call the brain shift or the brain herniation. So when that happens, so brain start herniating. So with further compromise the blood supply, causing the further cellular level injuries and brain to have a secondary impact. Right. So this is when the rest intracranial pressure, this the equation cerebral perfusion pressure equal to mean arterial pressure minus ICP. So ICP is high. So then our body has to, the heart has to pump more blood and which is higher pressure. Then so mean arterial pressure has to be maintained to have the cerebral perfusion pressure. So when we given these numbers, ideally the cerebral perfusion pressure, the targeted is 60 to 70 as Dr. Sanjeewa mentioned. And then for that, if we take the intracranial pressure as the highest, the upper normal limit as 20, then at least you have to maintain the mean arterial pressure of 90. So all these things to maintain the cerebral blood flow at least around 50 ml per 100 grams per minute. So if the cerebral blood flow drops below 20, there are reversible injuries, and if it is further drops less than 10, usually the brain results in irreversible permanent damages. So it's very important to maintain the cerebral blood flow, thereby have the cerebral perfusion pressure increased. When the increased intracranial pressure there, so which is increased intracranial pressure, the mean arterial pressure and the cerebral perfusion in this equation, which determine the cerebral blood flow as I mentioned before, and we have to prevent the cerebral herniation. So if this is uncontrolled, can cause the secondary brain injury as I mentioned. So part of this, what is this autoregulation? In the brain, so it itself can maintain the blood pressure within safe limits. So the ability to maintain the stable blood flow the sympathetic tone of the blood vessels, the vasoactive various substances like hydrogen, potassium, oxygen, and metabolic responses like carbon dioxide and pH responses. So all these things contribute to maintain the adequate cerebral blood flow, about, as I mentioned, 150 ml per 100 grams of brain. Usually this auto-regulation, mean arterial pressure between 60 and 160, cerebral blood flow is around static and it is about 50 ml per 100 grams. So the second graph shows the mean arterial pressure. It between 50 and 150, the static 50 ml per 100 grams of brain. So it's static. The first paragraph, it says that when there is an intracranial volume appears, it increases the intracranial pressure. But however, intracranial pressure maintained that with this auto-regulation and various mechanisms as I mean used in the Montefiore doctrine, so it maintained the cerebral intracranial pressure. However, at one point rapid rise in intracranial pressure occurs. We should never come to that point. We have to have our management within this compensated state. If you come to that point, it's very difficult to control the brain herniate and result in the secondary brain damage. Again, in this first paragraph, it shows the cerebral blood flow drops. Usually up to 20, it very well maintains all the cellular level functions. And if it is less than 20 ml per 100 grams of brain, so it's, as I mentioned, reversible injuries. We should never allow that to happen. And if it goes further down, it's irreversible, the ischemic co-irreversible injury. What we have to do is we have to protect the brain with this ischemic penumbra, where we have to take the action. So these are the usual signs. So in our patients in head injuries, they may come in coma, decerebration, and Cushing's triad. So we have to be very careful when monitoring all these signs and symptoms. There are two ways of management of raised intracranial pressure: medical management and the surgical management. So today's my topic is not on medical management, it's on surgical management. So what are the options? So we can evacuate if there is a space occupying lesion like SDH, EDH, extradural hematoma, subdural hematoma, so we can evacuate that. Or if we think that there is a raised ICP, then we can put an external ventricular drainage and we can internally decompress the brain and reduce the intracranial pressure. And the third option is decompressive craniectomy. So we are not going directly to the decompressive craniectomy. There's a tier management, as Dr. Sanjeewa describes, tier 1, tier 2, tier 3. So I will not go into stage 1 and 2 management, which is basically the medical management. But if it is uncontrollably elevated intracranial pressure, so then we have to take two actions. The trials are there, the barbiturate coma, which is again a medical management, a way of managing intracranial pressure, or else the decompressive craniectomy. So what are the evidence of decompression? There are two well recognized original trials are there. They are landmark randomized control trials, which is DECRA and rescue ICP. Both are decompressive craniectomies. The DECRA is the early stage of decompressive craniectomy, and the rescue ICP trial is the little bit of delayed and which has the higher ICP targets. As I mentioned, DECRA trial is the early bifrontal, temporal and parietal craniectomy, and basically for the moderately elevated, their ICP targets are about 20 millimeter mercury, and which is the early phase of the injury, and it has to be happen within first 22 hours of injury. And so after the DECRA trials, I will talk about the conclusion later. So what is rescue ICP? Rescue ICP is tolerate the ICP of up to 25, and which is again, it can be delayed even up to 10 days. So these are, as I mentioned, randomized trials. So what are the results of these two? So after the DECRA trial, so when we do the decompression, you can see in this graph, the rapid fall in the intracranial pressure. So it's very effective in controlling the intracranial pressure. And what are the results? So both these trials, basically they assess at 6 months post-trauma, and I don't know whether you can, they use this Glasgow outcome score, and which is extended one, which is it range between the death, vegetable state, and the full recovery. So the upper line is the surgical group, and the second one is the medical management group. And in black, it shows the deaths. So when compared to the medical management, the death number has been reduced in the surgical management. Obviously, after decompression injury, the number of deaths has been reduced. But when you look at that orange and the red lines, so which are the vegetative states and the poor recovery, the poor disability grades. So that means even though they survived with the vegetative states or with disabilities. And when you go towards the right side of the graph, the blue and the dark blue and the green, they are the good recovery. So there's no major impact on that. But what this says is, even though after decompressive craniectomy, though they survive, but they survive with a lot of disability, then it comes the problem what happened to these trials. So in these trials, both these trials, ultimately they say, even though they survive with disabilities, and long-term prognosis is not is unfavorable. So in conclusion, most of these following the decompressive craniectomy, unfavorable long-term outcome, and which cause the prolonging the agony. So are we prolonging the agony? Yes. There are patients who recover in the vegetative states with disabilities, and most of them are dependents. Now, is that true? So for example, now I'm going to take this one of my patients whom I have managed. This patient's D, a 53-year-old father of 3 children, and fallen from a roof and came with GCS of 7, and which dropped to 5, and pupils were 2 non-reacting, and he was intubated at the emergency room. And because he has fallen from the height, there is no radiological evidence of spinal injury. So this is first CT scan. If you look at that, you can see this posterior fossa is very tight, severe injury. The basal cisterns are occluded, effaced. And there's some evidence of diffuse brain injury, and intraventricular hemorrhages is very tight, ventricles are effaced. So this is a very bad head injury with GCSF, I mean severe head injury. So we need to do something. Right, and rapidly with this, patients rapidly deteriorate, pupils start dilating. So initial management was started, mannitol was given, and then insertion of EVD, and the posterior fossa decompression was done. Actually this is posterior fossa decompression which I did. And then he was paralyzed, ventilated for 48 hours, and he had a prolonged ICU stay more than 6 weeks, and he gradually showed some improvement, and his hospital stay was 6 months. And with there are a series of scan, this is immediate post-op scan after posterior fossa decompression. It shows some release of posterior fossa pressure, and the ventricles and the rest of the brain looks some improvement. And within the course of his stay in the ICU, there's gradual improvement of cerebral edema, and brain was starts slowly improving. So over a period of time, now it has gone about nearly 1 year. This was recently. So he can walk, his the vertical states maintained, and his the hand-eye coordination is better. He has some independency, so he know what to do. His cognitive is there, so he understands things, he recognizes people, so he can move the wheelchair. There's some improvement is there. I think Dr. Chamara would definitely be happy with this management who came with so see, he can do some maneuvers with his hand. Yeah. So this is his family, 3 children and wife. So this is prolonging agony. So what family needs is a man, father, and the husband. So this is a decompressive craniectomy. Even though with some disability he is surviving, so is it a prolonging agony? This question to you. Thank you.
Thank you, Dr. Nirukshan, for comprehensive discussion and giving you a hands-on experience about good outcome. And that shows that doing a clinical decision, rapid clinical decision, besides the 2 trials said about the vegetative state and complications, still getting into taking the patient to theater and doing the surgery made the wonderful recovery. Thank you.
So we thank all the 3 speakers for their wonderful presentations. Any questions that the audience has?
Hello, sir. I'm Dr. Majid from India. My question is there any role of cystonostomy while doing the decompressive craniectomy?
Yeah, so nice to hear about cystonostomy. So I was about to talk about cystonostomy, so even though we don't have class 1 evidence, so I have been practicing cystonostomy for the last 6 years, and I have done more than 100 cases in cystonostomy. So what I have seen is, when you compare with the decompressive craniectomy, so obviously the first reason I did cystonostomy mainly because I didn't have much faith in cystonostomy, to be honest, because Iberian is my friend. But I did cystonostomy mainly to reduce the cranioplasty rates. And I was able to reduce the cranioplasty rates to 21% with all my data I have done with the cystonostomy. Because, you know, I was working in peripheries and the cranioplasty is difficult because of the financial issues, because the mesh cranioplasty is a little bit expensive in Sri Lanka, and we didn't have refrigerated facilities in peripheries as well to, you know, to preserve the bone flap, and used to put the bone flap to the abdomen, but that was not very good after few months. So that was my main aim. But when you look at the the neurological outcomes, what I have seen with cystonostomy is that we have remarkable and early good neurological outcomes with cystonostomy compared to the decompressive craniectomy. But with regard to mortality, I did not get any significant improvement when we talk about the statistical significance. But when you compare with the decompressive craniectomy and cystonostomy, number 1, you can put the bone flap back. So the cranioplasty rate is definitely reduced, and the remarkable recoveries, rather than when you compare to the decompressive craniectomy, is much higher in cystonostomy. But the drawbacks, you need a microscope, right? And you need the vascular expertise to open up the cisterns. I was able to do that because I had to go for each and every decompressive craniectomy because I was the only neurosurgeon at the center. And even at the night, I had to go and do the decompressive craniectomy or the cystonostomy. So I was able to do that because I was trained. But if you want to train your trainees or the medical officers, you know, it needs time. So we need to train the skills, the microscope. So there are drawbacks. And doing this, you know, at the late hours of night. So these are the difficulties and the drawbacks we have. But definitely we need to have these randomized control trials and class 1 evidence regarding cystonostomy, which is still, you know, it's lacking. So it's good that you came up with cystonostomy. And I don't know how many people in Sri Lanka, neurosurgeons, practicing that. I have been doing that. But we have drawbacks and difficulties.
Thank you.
I'm Dr. Kunadeepan, casualty surgeon. Regarding trauma head injuries, our line is medical treatment management. If fail is surgical management. If the surgical is not indicated for surgery, we go for the palliative. We just leave that. But we frequently get the opinion from that neurotrauma is not surgically indicated injury. basically the palliative. What is the level, how can we diagnose that is a surgery is necessary for surgery, or is it just straight away for the palliative management immediately after the admission and with the first CT scan?
Yeah, I think that question, there's nothing called the palliative management in head injury. Only thing is sometimes we decide there's no point of doing anything. So this is basically with no intervention. So it's a do not resuscitate kind of a patient. So that point that has to be decided by the neurosurgeon. If these patients come with severe radiological evidence of severe head injury and GCS of 3 and pupils are fixed dilated, hemodynamically unstable, and the patient does not have spontaneous breathing. So that type of patients, usually, if the images are suggestive of already cone brain, so usually we don't do anything, we just keep the patient comfortable. But rest of our management depends on the Glasgow scale percentage, the minor head injury, moderate head injury, and severe head injury. So minor head injury category, usually they can be managed in the general surgical wards. You don't do anything. What you need is you just observe the patient. The problems come with the moderate head injury and the severe head injury category. Severe head injury category, there's no question. Either they need some intervention, they goes to the neurosurgical unit, ICU, they need the surgery. And the moderate head injury, this is where the gray area sometimes. They might go back to improve to the minor head injury levels, or they can progress to the severe head injury category. So they need the very intensive monitoring. So most of these, actually 4 categories now, all 3 minor, moderate and severe, they have a set plan. But this severe head injury, there's nothing we can do about it. It's unsalvageable brains. So those are the patients we say as unsalvageable brain, and we don't do anything for them. Thank you.
Okay, thanks.